everyone. And I should also say the chairperson that I am also trained in South Korea with Dr. Park and Dr. Lim, Professor Lim from Korea University Medical Center. So I am not new to Seoul. So on the next 30 minutes, I would like to discuss, because the previous speaker, it's a continuation of the previous talk, where we have found the previous speaker has spoken about the equipment and this thing. I would like to show you how the IVAS guided PCI helps in the understanding the morphology, the plaque characteristics, and how to optimize the outcome. So I would like to go from the simple to the complex cases. The first one is almost a routine daily case where you see acute coronary syndrome in a patient with presenting with atrial MI, young patient who is a smoker and atrial MI, is a low ejection fraction. So that's the angiogram. You can see it's just a proximal to medial AD. There is a stenosis, and you can see that's the imaging. You do the IVAS imaging. You can see from mid to proximal AD there is a plaque. There is a areas of calcification, although we were not able to see in angiogram. And if we come further in the proximal AD, there is a plaque here, a collucent region, and there are few calcifications. So probably there is no clear rupture evident in this plaque. This like a moon shape. This is the soft plaque. So coming closer, so the disease is extending up to the ostial LAD. So again, just compare both the imaging side. The same slide set, you can see the IVAS. So look at these OCT images of the same patient from distal to proximal. Here you can see the clearly evidence of a plaque rupture. Here in this is a cavity, more of a lipid substance, and it's very tight stenosis here. And this is the thing. So look at so OCT helps in more understanding plaque morphology and this thing. IVAS helps, but we cannot clearly delineate the morphology and characteristics of the plaque. So again, this patient underwent a PCI, and this is the post PCI where these are the stent walls where it is well opposed. So that's the angiogram of this patient. This is a simple patient, so you're looking at the plaque characteristics and morphology. Another patient in a case of stable angina who is hypertensive, TMT positive, and a normal ejection fraction. So there is a discrete lesion here. So look at the IVAS findings. Here again there is a plaque which is as the intensity same as the adventitia, so it's like a fibrous type of plaque. So look at the virtual histology. You can see virtual histology tells you whether it is a fibropathy, fibrolipid, red color is the necrotic core or the dense calcium. So here it's predominantly is a fibrous type of plaque. This is stable coronary syndrome patient. You have a less of necrotic core. So this patient undergoes a PCI, and that's the result. So again, a case of inferior valve acute coronary syndrome, inferior valve MI, young patient, ST elevation MI, inferior valve MI. So you can see this occlusion is like this. This is angiographically there's lot of thrombus. So this I was finding the wire went to a branch, and look at this, clearly identify it has gone into one of the branches, and now coming closer, this second image, there's a large branch coming from the sideways. So this helps, IVAS helps in identification of the side branches rather than blindly going. It helps you like in CTOs also. So this is the patient. Again, with this help of IVAS, we have negotiated into the side branch, and this is the imaging from the side branch. So the virtual histology helps, and this is the algorithm for identify virtual histology. When a plaque thickness is more than 600 microns, 3 frames, necrotic or more than 10% with more than 40% of plaque burden. If yes, if you have a fibrous cap less than 65 microns, yes, and the dense calcium is more than 10%, it goes under calcified thick fibrocapotheroma. If not, it's a thin cap fibroatherectomy. So this is the algorithm given for classification according to the virtual histology IVAS. So in this patient, you have a more than 10% necrotic core, dense calcium less than 10%, but you don't have a thin cap because there is no necrotic core adjacent to the lumen. It has to extend adjacent to the lumen to say it as a thin cap fibroatherectomy. So this is just a fibroatherectomy. So our case is just a patient of inferior lumen with fibroatherectomy with necrotic core. So that's the result. So you can see there is some slow flow in LCX. So IVUS also helps in predicting what are the predictors slow flow. Positive remodeling, having a plaque rupture, IVUS detected thrombus, tissue prolapse are independently associated with a post-cardiac PCI troponin elevation. The more the necrotic core, the more likely to have a slow flow. So now is a case of very late stent thrombosis, young male post-PCI 2014. He has come with acute inferior valve MI with CHB. So you can see the clear previous stent there inside, and these are the IVUS findings after one thrombus aspiration. So here you can see there is a soft plaque in this region, and probably there is a rupture of this plaque. So this is a plaque rupture, probably neoatherosclerosis, which was developed after 5 years. So this helps in understanding what is the nature of the pattern of stent failure in long term. So neoatherosclerosis, this can be detected by imaging. So this patient undergoes a PCI when we put one more stent into it, and this is the result after that. So this helps in the understanding the nature of the plaque of stent failure after a few years. So this is a case of bifurcation stenting, young patient, family history of CAD, anterior MI presenting after 3 hours, EF is 40%, left ventricular ejection fraction. You can see from this angio there is a LAD, mid LAD, there is a disease 99% stenosis, and the diagonal is ostial to proximal more than 5 millimeter disease. So when you have a disease like this, angiographically this again goes for 2-stent technique because there is a tight stenosis extending from the ostial to the proximal portion. So this is from the diagonal. You can see there is a plaque, very mixed plaque, which is significant plaque burden. Again, the similar look at the OCT findings. So this is from LAD. You can see again there is a lipid pool, and there is some evidence of this a small white thrombi. So there was some interaction with the slides, and this is the LAD runs. Sorry, this post LAD runs. So this patient underwent a PCI bifurcation technique, 2-stent technique, and the post procedure you can see main is to achieve a good larger lumen diameter. This is from LAD and this is from diagonal. So if you have a diameter of more than 2.4 in diagonal and millimeter square, as large as possible, more than 4, you expect a good long-term clinical result. So this is the immediately after the angiogram, and look at this angiogram exactly after 1 year of this PCI. So you can see from this both are looking similar. After 1 year of angiography, you get excellent result with IVUS guided PCI. So again, IVUS in bifurcation helps in stent optimization. Again, some of the parameters like main vessel plaque thickness and side branch diameter ratio are predictors of side branch occlusion if you are using a single stent crossover. And again, in the complex disease subset left main bifurcation, is a 58-year-old male patient, hypertensive, unstable angina with low ejection fraction. So that's the disease. You have a distal left main disease extending into the mid to distal AD and ostial to proximal LCX disease. So left dominant circulation, LVF is low. And IVUS classification of LM bifurcation plaque, if angiographically it might look different. Look at this study. When a plaque is involving the distal left main, it's 90% of the chances that the disease extends to the LCX into the LAD. So we should remember that angiographically it might look normal, but if you do imaging, it gives altogether a different picture. Like so, in this patient, you have there is a calcific lesion from mid LAD, and look at this distal left main. You can see, although angiographically there was not much, there is significant plaque burden with a luminal area of just 2.21. So left main MLA less than 4.8 to 6 will correspond to a value of 0.75. So if you have a left main values less than 4.8. For the Asians, we should consider for PCI. So this is the pullback from LCX. So there was pre-dilatation with a balloon. Then here clearly you could see a rupture and rupture of the plaque. They are with a cavity inside. So this patient underwent, because there is a calcification, this one underwent a cutting balloon, and the two stent technique, bifurcation stent technique was done. So post procedure, you have to do, we get good MLA. You can see here from this, in the ostial LAD, you have a almost area of 11.08, and left main you are crossing almost 16. So the algorithm is like this: if you should get the bigger the better. The LCX ostium at least should be more than 5, LAD is 6, and polygon of confluence 7, and LM proximal 8. So this is the thing, and taking the runs from LCX, you can see we achieved a luminal diameters close more than 3.8 and very large diameters. So this is the final angiogram for this. So IVUS helps in understanding the distal left main bifurcation plaque and how to optimize the result. And this is the last case where in a complex case disease, you need to identify exactly what you are going to do, whether you want to do a provisional or two stent technique and all. This is a young patient who is diabetic, who has come with NSTMI and TROP positive and EF of 45%. It's not, it's okay. So this patient had a ostial left main to LAD tight 90% stenosis, and you can see this IVUS. So look at this ostial LAD and distal left main is called almost 1.62 diameter, and ML is just 2.5. Again, I was pulled back from ramus. You can see there's a mild plaque extending into the ostium of the ramus. Again, similarly from LCX, so there is only mild disease at the ostium of the LCX. So in this angiogram, you have a disease extending mainly from the left main to LAD, and it's a mild disease from the ramus and the LCX. So we can plan for a provisional strategy. So we want a provisional strategy with single stent from left main to LAD, and this is the IVUS findings from LAD to LM. So after 1 year angiogram, there was it was a good result. So looking at from the various studies, you can see there is now enough evidence to suggest that IVUS guided PCI is more helpful as compared to angiography guided IVUS. So even for the left main disease, now from the multiple studies, we have the data to suggest that especially in left main disease, it becomes an indication to do an imaging prior to intervention. So the utility of IVUS is stent underexpansion is the most important cause of death failure. You have to try to achieve minimal MSE of at least 5 to 5.5, which is the best predictor of IVUS for first generation deaths, for restenosis and early thrombosis. So again, in left main, it prevents late thrombosis from these both studies, and it also IVUS guided PCI helps in the use of contrast. So my take home message would be like intravascular imaging has to be done as frequently as possible, and it improves the better long term outcomes. Thank you for your kind.
Very excellent and educational cases. Is there any comment or question from the floor? I'd like to ask some question. You emphasize the mainly plaque characteristics in the use of the IVUS in the PCI procedure. What is your main purposes to IVUS or the OCT in the PCI procedure?
Yeah, for us, we are doing studies on the plaque characteristics and morphology in ACS patients. So we do a lot of IVUS. And the second thing is, for every complex cases involving either bifurcation stenting or complex cases, we do imaging.
Usually, one of the common usage of the IVUS is the selection of the stent length and stent size is more commonly more practical. So when you look at just the angiogram, you usually select the small size one and the small shorter length of the stent. However, doing the IVUS, you can have a more strong evident confidence of your procedure. You can select a more bigger one. And your last presentation is angiographically. Sometimes we have some dilemma. selection of the the side branch vessel or not. In your last case is the confirmation with the presence and the severity of the plaque in the side branch vessel. For example, in the ostium of the circ and the ostium of the ramus, and then we will change the treatment strategy. For example, 2 stent, then from just a single crossover. Is that one of the strong message of the imaging, particularly in the bifurcation region. And the another issue is in the bifurcation region. Is what is the most important point to look at it in the bifurcation region? What I mean is just doing the IBIS or the OCT in the bifurcation. What do you look for after the stent in the bifurcation region? What is the key point have to see in the IBIS images? 2 stent, particularly in the 2 stent technique.
So in this case, it was almost a 15 millimeter length, and it is a large side branch, and a young patient. I think we considered 2 stent technique.
Proper opposition of the stent to the carina and carina formation.
Yeah.
That is one of the most important thing we have to see in bifurcation. And how much protrusion is there as far as the bifurcation stent is concerned into the main branch. Another thing is that the biggest advantage of IVUS over OCT is that there is no need of using additional dye. So dye constraints are always not there, so we can finish the procedure in patients with a renal insufficiency. We can do that particular thing. And in patients with the ostial left main, OCT is not a good option because it doesn't opacify the ostium of the left main, because for opacification in OCT we have to always fill the vessel with the dye, and then it is not possible. Another thing, in patients with significant stenosis, and if you are doing IVUS, if you people are doing all echo, and in echo because of severe mitral stenosis you will get a spontaneous contrast. The same thing happens in the distal vessel. When we put the IVUS catheter in significant stenosed vessel, so you will get a spontaneous contrast, and then sometimes you might not able to characterize the plaque because of that spontaneous contrast in that particular segment. That is the one observation.
I'd like to emphasize in the bifurcation stent, particularly in the 2 stent technique, the angiographically there is no stenosis, very minimal residual narrowing, perfect. Even in the TK crush, or sometimes in Guillot, and sometimes a provisional T-stenting or T-stenting is angiographically perfect. However, when we do the IBIS, there is a lot of the stent strut was exposed to the above the bifurcation area. So what is the real perfect the bifurcation stent technique is anyhow try to avoid any presence of the stent strut above in the bifurcation cone. So you have to very seriously search for is there any presence of such kind of stent strut. Second one is the emphasis in the focus of the side branch ostium, particularly because side branch vessel is essentially a small one. Try to get the larger area. So if you do not the imaging, looks like angiographically acceptable, so just let it alone. However, when we really measure that, is sometimes we can find some suboptimal the area. So therefore, we have to use the imaging, particularly in the complex lesion. Any comment? Okay, good job. We will move to the next presentation. The next presentation is the OCT guide PCI cases will be presented by Dr. Sengo Tu Bellu. Sorry to my